We're going to be discussing arterial blood gas compensation. Nurses must be able to interpret arterial blood gases in order to make sure their patients are getting the proper care. You've already had the opportunity in earlier courses to start this process. What I'm going to be focusing on during this video is how to evaluate whether compensation is occurring in arterial blood gases. An important thing to ask before we even get started is, why is it important to be able to evaluate ABGs? ABGs gives us two vital pieces of information that we need in order to provide safe care. First is the acid-base balance status of our patient. Are they in the proper balance, which is between 7.35 and 7.45? Or are they out of balance and either acidotic or alkalotic? So that's an important thing to know. And secondly, it gives us important information about their oxygenation status. And that's obvious, an important number that we need to know. In terms of acid-base balance, you look at the ABG components of pH, PCO2, and bicarbonate. For oxygenation status, you're going to be focusing on the PO2 and the O2 sat. So let's define compensation and talk about why it is so important. Compensation is what the body does to try to restore the pH back to the normal range and maintain homeostasis. If the pH is out of balance, a lot of bad things happen. First, a series of enzymatic changes are going to be affected, and ultimately it's going to impact the patient's ability to oxygenate and to give up oxygen at the tissue level. So it's only, you can see, a very narrow range that the body really needs to be in, 735 to 745. There are some instances where the body is unable to correct the underlying problem. And a good example of that would be if you had a patient who has COPD. A patient with COPD is always going to have an elevated PCO2 level. There's really not much we can do about altering that. It's part of the pathophysiology of the disease. And we know if people with elevated PCO2 levels, they're going to be in respiratory acidosis. And that is not something that we want them to stay in. So what compensation is the body works in this case through the kidneys to try to save bicarbonate, not excreted out through the urine, to try to buffer that extra acid load. There's two different types of compensation, two different organs involved. The first is respiratory compensation, and we can tell that's occurring by focusing on the PCO2. The important thing to know about respiratory compensation is that if it is present, the lungs can compensate very quickly, within minutes, in the presence of a pH abnormality. So the lungs can either do one or two things. They can either speed up breathing, and by doing that, you'll be able to blow off more PCO2. Remember, CO2 is an acid. CO2 plus water is carbonic acid. So when you elevate the respiratory rate, when you increase the respiratory rate, you blow off CO2 and you become more alkaline. So we can do that very quickly with the lungs. Similarly, if we have an alkalotic situation where the body is too alkaline, there's too much base, what the body can do to try to compensate for that is hang on to CO2. So in that case, respirations would slow and it'd become less deep. By hanging on to CO2 or acid, you're going to mitigate the effects of that extra bicarbonate load and hopefully be able to compensate for the alkalosis that is present. So respiratory compensation is a powerful way to try to maintain homeostasis, and the good thing about it is that it can happen within minutes. The second system that compensates in arterial blood gases is the kidneys, and that would be metabolic compensation. When we talk about metabolic compensation, we're focusing now on the bicarbonate, HCO3. The thing to realize is that if you see that metabolic compensation is taking place, you know that the ABG abnormality has lasted longer than 24 hours or more. It's certainly not as quick as respiratory compensation. So if we have an acidotic situation, the kidneys will compensate by hanging on to bicarbonate, by not allowing it to be excreted through the urine. If we have an alkalotic situation, the reverse happens. If it's too alkaline, if the body is too alkaline, the kidneys will excrete bicarbonate to try to mitigate the alkalosis and bring the pH back into a more normal range. So through the lungs and through the kidneys, compensation is a very effective tool to try to maintain homeostasis. So let's review the steps of ABG interpretation. Certainly you've been doing some of these steps as you've taken earlier classes in ABG interpretation. The first, of course, is to look at the pH and to determine if acidosis or alkalosis is present. And that's pretty simple. Acidosis would be if the pH is less than 7.35, and alkalosis is if the pH is greater than 7.45. The second step is, if there is an abnormality, to determine if it is a respiratory or metabolic cause. And we do that by evaluating the PCO2 for the respiratory and the bicarbonate for metabolic. Once we have determined the cause, step 3 then is to determine if compensation is occurring. And to do that, you're going to be looking carefully at the PCO2 and bicarbonate. If both are abnormal and both are heading in the same direction, meaning both are increased or both are decreased, that's the red flag to you to know that compensation is occurring. So again, if compensation is occurring, if you see the PCO2 and the bicarbonate both being abnormal and both being elevated or decreased, heading in the same direction, that's the clue that there is compensation occurring. The fourth step of ABG interpretation is to determine if this compensation is fully compensated or partially. And that's an easy thing to do. If you see evidence of compensation and the pH has returned to the normal level, meaning the 7.35 to 7.45, if it's within that normal level, we consider that fully compensated. If we see compensation occurring, but the pH is still abnormal, meaning outside the 7.35 to 7.45, we consider that partial compensation. And finally, the last step of ABG interpretation, which we don't want to forget, is to evaluate oxygenation status. And we do that, of course, by looking at PO2 and O2 sat, as it gives us very important information. So as I mentioned, just to sum up, how do you know that compensation is occurring? Again, it's by looking at those two key indicators, HCO3, bicarbonate, and PCO2. If we see them both being abnormal, both heading in the same direction, both elevated, both decreased, whatever the situation is, then we know compensation is occurring. Partial compensation is if we see that compensation occurring and the pH has not returned to normal. Full compensation is when compensation is occurring and the pH is back within the normal range of 7.35 to 4.5. One thing about fully compensated, if you have determined that the compensation is occurring and the pH is normal, if compensation is occurring, the pH will never go to the exact middle, which would be 7.40. The pH will always lean towards the side of the abnormality. So let's say if the underlying abnormality is a respiratory acidosis. Even though the bicarbonate is increased to try to compensate for that increased acidotic load, our pH may be normal, but it's always going to lean towards the 7.35 side. It's never going to totally get back to the midpoint. So that's a clue for you. So that's why with ABG interpretation, it's very important that you not stop at pH. Some people look at the pH and when they see that it's normal, they kind of stop there and say, oh, it's a normal blood gas. You can't make that determination without first looking at PCO2 and bicarbonate. Because while you may see a normal, quote-unquote, normal pH, if you're seeing abnormalities in PCO2 and bicarbonate, something else is going on, and it very well may be compensation. So here's a chart that just talks a little bit about partially compensated blood gases, and it lists the 4 different abnormalities that we might see. So respiratory acidosis. Certainly with respiratory acidosis, we know the pH is decreased. The PCO2, since a respiratory cause, is going to be increased. That's that COPDer who gets the flu and is retaining CO2 and not breathing so well. So we know that their PCO2 is going to elevate. That's causing their respiratory acidosis. If compensation is occurring, the bicarbonate will also increase. Remember, we said we look at PCO2 and bicarbonate. If both are abnormal, both heading in the same direction, in this case increased, compensation is there. But the pH has not completely returned to the 735 to 745. It's still decreased here, so we would consider this partially compensated. For respiratory alkalosis, again, for alkalosis, our pH is going to be increased. And because it's an underlying respiratory cause, the bicarbonate is going to be decreased. That's the problem. This would be somebody who's hyperventilating. So what will the body do to compensate? It's going to decrease bicarbonate, HCO3, to try to get rid of that extra base so we can get that pH back into a normal range. But since the respiratory alkalosis, since the pH is increased outside of the normal range, we would consider this partial compensation. For metabolic abnormalities, for metabolic acidosis, again, the primary problem is that the bicarbonate is decreased. So the compensation that will occur is the PCO2 will also go down to compensate because we want to get rid of acid. But that pH still is outside the normal range, so we would consider it partially compensated metabolic acidosis. And finally, for a metabolic alkalosis, the primary problem again is that the bicarbonate levels are too high. The body will compensate by hanging on to PCO2, not breathing as rapidly, kind of taking shallow breaths. So both the PCO2 and bicarb are abnormal and heading in the same direction, in this case increased. But the pH has not yet returned to the normal range, so we would consider it partial compensation. So let's practice. Let's give it a shot here. So we have a patient who admits to feeling poorly for the last week. We draw ABGs, and this is the following result. We have a pH of 7.30, a PCO2 of 28, and a bicarbonate of 16. And the question is asking which of the following is the correct interpretation of this arterial blood gas. So again, let's go back to our steps. The first step is to determine acidosis or alkalosis, and we do that by looking at pH. So our pH is 7.30, which is outside the normal range. Normal range is 7.35 to 4.5. So we know that we're talking about acidosis here because the pH is less than 7.35. That's step 1. Step 2 is to determine whether there is a respiratory cause for the acidosis or a metabolic cause. So let's start with respiratory. If it was a respiratory acidosis, we would see that the PCO2 would go up because CO2 is an acid combining with water, forms a carbonic acid, and the body would be too acidic. So we ask, is the PCO2 elevated here? And the normal PCO2 is 35 to 45, and it is not. So it is not a respiratory cause. Rather, the PCO2 is not high, it's low. So then we say, well, is it a metabolic acidosis? And if it was a metabolic acidosis, the bicarbonate level, the base, would be low. Normal bicarbonate is 22 to 26, and our bicarb here is 16. So the underlying pathology of this blood gas is we have a metabolic acidosis. So that's our second step. So our underlying problem, metabolic acidosis. Our third step is to determine if compensation is occurring. And remember our rule. If we see that the PCO2 and the bicarbonate are both abnormal, in this case they both are abnormal, and both heading in the same direction, which they are in this case, the PCO2 and bicarb are both low, we know that compensation is occurring. So in this case, the lungs are trying to compensate for the metabolic acidosis. So we do have compensation occurring. Our fourth step then is to see, is it partially or fully compensated? And that's easy. We look at our pH. Is it within the normal range? And it is not. We are still below 7.35. So our interpretation, there's no oxygen levels to interpret here, but our acid-base interpretation of this blood gas then is a partially compensated metabolic acidosis. So we went through our steps and we got the right answer. So to sum up this problem again, why is that the right answer? First, because the pH is low, 7.30, acidotic. We know the underlying cause is metabolic. The bicarbonate is low, it's 16. And we know that it's not respiratory acidosis because the PCO2 would be high. And in this case, it's not, it's low. So the underlying problem is a metabolic one, metabolic acidosis. Is there compensation occurring? We said that yes, it was, because both the PCO2 and bicarb were abnormal and heading in the same direction. In this case, they were both going lower. So that defines for us the compensation is occurring. And finally, we said that it was a partial compensation because the pH was not yet back to the normal range. It's 7.30, which is below the 7.35 end of the normal range. So our final interpretation then is that we have a partially compensated metabolic acidosis. Let's talk fully compensated now. Now this is the one that may cause some confusion because when you first look at the pH will be normal. That's the definition of fully compensated. The pH is within the normal range. But remember we said that it will never probably get to the midline. It'll never get to 7.40. It's always going to lean towards the side of the abnormality. So let's look at this chart. So if we have respiratory acidosis, the pH we say is going to be normal if it's fully compensated, but it's going to lean towards the acidotic side. So that means it's going to be less than 7.40, closer to 7.35. The PCO2, since it's a respiratory acidosis, is going to be high, and the body compensates by raising the bicarbonate. That's going to be high as well. Both of the PCO2 and bicarb are going to be high, heading in the same direction, abnormal. We know compensation is occurring. For a respiratory alkalosis, we know that the pH, if it's fully compensated, is going to be normal, but again, it's going to be higher than 7.40. It's going to be closer to that 7.45 range. Both the PCO2 and the bicarb will be decreased. For metabolic conditions, for metabolic acidosis, again, the pH is normal, but closer to 7.35. The PCO2 and the bicarbonate are both going to be decreased. And for metabolic alkalosis, more alkalotic, the pH is going to be closer to 7.45, and both PCO2 and bicarb are increased. So again, the importance of not just stopping at evaluating the pH. So here's another problem for us. So we have a patient with COPD who's admitted for surgery. An arterial blood gas is obtained, and these are the results. The pH is 7.35, the PCO2 is 48, and the bicarbonate is 28. And we're asking for the correct interpretation for this arterial blood gas. So let's go through our steps. First step is look at the pH. It's 7.35. Well, it's within the normal range, but again, it should light a little red flag. It's certainly normal, but it is, without a doubt, more towards the acidotic side of the range. So now we need to say, if that is a compensated blood gas, let's look at the PCO2. Is the PCO2 high or low? And in this case, it's high. Normal is 35 to 45, and this is 48. So what do we know here? With a PCO2 of 48, we would expect that blood gas, that pH, would be more acidotic. What do we look at when we look at the bicarbonate? The bicarbonate is also high. So again, the two levels, PCO2 and bicarb, heading in the same direction, abnormal, in this case both high. So our underlying problem here is a respiratory acidosis. But what has the body done? the kidneys have hung on to bicarbonate, not allowing it to be excreted in the urine. So what we see here, and since the pH is back to the 7.35 level, what we have here is a fully compensated respiratory acidosis. And again, remember what we said initially, that if we're seeing metabolic compensation, we know that the abnormality has been in place for longer than 24 hours. So the correct answer problem is we have a fully compensated respiratory acidosis. And then again, the pH is within the normal range, but leaning acidotic. The PCO2 is elevated, saying that our underlying cause of the acidosis is respiratory. The bicarb, it's not a metabolic acidosis, because if that were the case, the bicarbonate would be low, and in this case it's high. So that's not causing the acidosis. It's certainly an evidence of compensation. So is compensation occurring? Yes, because it meets our definition. Both the PCO2 and the bicarb are elevated, out of the normal range, both heading in the same direction. And since the blood gas, the pH, is within the normal range now, just within, we would consider it a fully compensated respiratory acidosis. So, now it's your turn. I've posted on Blackboard a set of problems, 10 problems, that deal with compensation, and I've included the answers. So the first place to start is there. Do a few of those problems. If you're getting them correct, you can proceed to doing your ticket to class. The ticket to class for class this week is you're going to be doing 5 arterial blood gas problems on Blackboard, printing them off and bringing them into class. That's going to be the first thing we're going to talk about at class this week. So if you have any questions about this content, I've listed my email address. Please feel free to send an email, and we can discuss it more. But again, I can't overemphasize the importance of ABGs. We're going to be talking about extensively not only this week in our class, but also in our class next week when we talk about patients who are mechanically ventilated. So please let me know if you have any questions.